going to present, bringing hospice and palliative care to the long-term nursing sector. I think it's really quite elaborated by now. It has expanded into various sectors of long-term care. And all the people from my organization, from Diakonia, were too shy to do it in English. But I knew that Maria, they're working with Hungary and with other countries. And so she was brave enough to do it. And I'm sure she's competent enough by far to do it. And I'm very happy that we can present what we have developed here in Austria. And Maria will present what Hospice Austria is.
I'm delighted to spend the next hour with you and tell you something about our projects in Austria. A little bit about me. My name is Maria Eibel. I live in Lower Austria, which is around about 70 kilometers away from Vienna. I work for more than 13 years in Hospice Austria, and I'm responsible for the so-called Grundversorgung. That means there is no way to translate it, so I always will call it Grundversorgung. And it means Grundversorgung that these are the non-specified hospice and palliative care organizations, like nursing homes or home care services, hospitals, and general practitioners. My background, I studied health and nursing sciences and social work. I will share my slides with you. One moment, please. So I hope you all can see it. To get an idea about Hospice Austria, in our office, we are 9 staff members and 4 volunteers, and we were grounded in 1993 in Vienna. So it doesn't work to get to the next. Okay. Hospice Austria is the nationwide umbrella organization for hospice and palliative care organizations. In 8 out of 9 counties, we have regional umbrella organizations, like, for example, the hospice movement in Salzburg. And there are the CEOs of those regional umbrella organizations are board members of Hospice Austria. And there are about 400 organizations in Austria which we represent. These are mobile palliative care teams, palliative care units in hospitals, inpatient hospices, and hospice volunteer teams. On the next picture, you can see Hildegard Teuchels. She is the founder of Hospice Austria, and there she's with Cicely Saunders on the Palliative Care Congress in Montreal in the year 2000. Our mission is that palliative care shall be accessible, available, and affordable for all people living and dying in Austria. The main areas of focus are developing a nationwide hospice and palliative care infrastructure and securing its funding. Another point is that the quality assurance and quality development of hospice and palliative care development in Austria, the quality assurance and quality development of education and training for professionals and volunteers, and the education of and information for all people who are living and dying in Austria. First, I want to tell you about the project Hospice Culture and Palliative Care in Nursing Homes. Then I'm going to present you a lot of details about this project, because the other project in the home care services has the same content and structure, and it's only the setting that's different. Yes. As I mentioned before, I'm responsible for the organizations of the Grundversorgung. The the Grundversorgung, as I told you before, includes hospitals, long-term care facilities such as nursing homes, mobile care support services, and the general practitioners. Around 80 to 90% of all people who die in these organizations of the so-called Grundversorgung. A lot of them have palliative care needs, but they do not need specialized hospice and palliative care organizations to get the care they need at the end of life. In contrast, only 10 to 20% of all people who die in Austria die in specialized hospice and palliative care organizations, for example, in palliative care units in a hospital. To get an idea, there are 88,000 people who die in Austria every year. And these 80 to 90% of people who die in the facilities of the Grundversorgung are also one of the key reasons why we at Hospice Austria have taken up this tissue and started the project. There's the increasing age of all the people, the rising of numbers of chronic and incurable diseases, and the need for palliative care also in nursing homes is clear. Dying has changed compared to the past. In the past, when someone was ill, they either recovered quickly or died quickly. Today, dying has become a slower process, especially for geriatric patients. The general condition gets worse. It occurs in phases, resulting in many crises. They often are brought into a hospital, which could be avoided. Nurses say that they need more knowledge and skills to cope with all the residents who move in the nursing home and who are dying there. So it's the last residents of the people who move into a nursing home. We started the project Hospice, Culture and Palliative Care in Nursing Homes in the year 2004. There are more than 900 nursing homes in Austria, and 225 nursing homes have already implemented the project. And yes, the goals of the project are, on the one hand, to create awareness and security. This means that staff realizes when residents are entering end of life or the final phase, when conversations with relatives are needed, what needs to be discussed at the end of life, with whom, and whether the involvement of a palliative care team is required or not. And we also have to make the staff aware of that hospice and palliative care must already be considered when residents are moving into a nursing home. What does it mean for people to leave their familiar surroundings? What losses do the residents have to accept and work through when they move into a nursing home? There is also grief processes already begin at this stage. And not only for the resident who comes to the nursing home, also for his family and friends. Another point is that we want to empower the staff. A lot is already being done in the nursing homes, but it's often not called, okay, we make palliative care, we support palliative care, we do so much. Often it's pushed into the background. And one focus is we call it uncovering the treasures. So we identify what is already done there in the nursing homes at the end of life for their residents. And another step is to to work with them on the processes and also look at that what has already been achieved, but also what needs further refinement. We create new structures in the nursing homes. We introduce a so-called palliative care group and at least 2 palliative care coordinators. And we work on the process in the nursing homes, from the moving into nursing homes until dying of the residents. We want to make sure that sustainability is really implemented at the beginning of the project. So we try to think it, as I said, from the beginning, so that it doesn't appear when the project ends. About the implementation, the project Hospice Culture and Palliative Care in Nursing Homes is an organizational development project, which includes also trainings for all the staff. There's also always the question, why do we need organizational development? Employees, as you all know, come and go. There is often a high turnover. When certain content depends on one person, individuals, and these people leave the nursing home, all formal and informal knowledge is lost. So we try to change the structures and processes to really implement it sustainable. Yes. Organizations learn through different things. One is cultural change, but also through communication structures, how are decisions made, and to look at the processes, how decisions are made in the nursing home. And it's also, you all know, cultural change takes time, needs a lot of energy to really change something. And it's important to start with the managers of the nursing home. They must really, how do I say, they really have to
embrace.
Yeah, to embrace and to be aware of why this theme is needed and why the employees need it, why the residents need it, and also the families and friends of the residents. Otherwise, it won't be sustainable and lost after the project ends, as I mentioned before. And we try to involve all the employees in the project. People learn a lot through the trainings. But however, when they return from the trainings and the structures remain unchanged, they are often unable to implement much of what they've learned. And it comes to misunderstandings and they lose motivation because they can't implement new things they've learned in the trainings. Sometimes the suffering even increases as they know what to do, but they can't do it because the structure hasn't changed. Yeah. When we start the projects, which last 2 to 3 years, depending on the size of the nursing home, we start with a situation analysis. So what is done to palliative care, what is already implemented, and then we work on the goals, performance, and indicators. This is a nationwide paper which includes the main goals of the project and answers the questions, when I go into a nursing home, how can I tell or feel, or how do I realize that hospice culture and palliative care is practiced here? So when I enter the house. And as I said, everyone is involved in the project. And this document, Goals, Performance and Indicators, has issues for the managers, it has issues for networking, and it has issues for the employees, for the members of the nursing homes. For example, how do new employees get to know that this project is in the nursing home? How do they, when do they get in the trainings for hospice and palliative care? Or for the managers, do they have enough budget to make the trainings in the next year? Do they speak in the team meetings with their employees about hospice and palliative care and the improvement of hospice and palliative care, and so on? So there are a lot of points in this document, goals, performances, and indicators, which worked through in the 2 to 3 years when the project is implemented, but also after the project ended. The document is still a very good, I would say a very good, what's it called, Rahmen, very good
Framework.
Yeah. With the contents of palliative care. Yeah, to the trainings. The trainings in geriatric palliative care are long 36 hours. There are a maximum of 20 people in one training, and it's made with the storyline method. As you see, there are 3 characters which are created. A resident, in this case it is Johann, a relative or caregiver, this is his wife Toni, and a caregiver, this is Schwester Maria, or Nurse Maria. And the characters are used in training to work on various topics that may arise from moving into a nursing home to passing away in these 36 hours. All staff members are in the same training, also people from the kitchen, from the cleaning service, the in-house technician, the manager of the nursing home, of course, the nurses. Yeah. At the end of the project, it's the aim that 80% of all the staff members should have been on the training. The content of the training is definition of palliative care and palliative geriatrics, typical biography of a resident, quality of life in old age, curative and palliative measures, working with relatives and relatives as a target group for palliative care, also advanced care plannings, symptoms of dementia, use of pain assessments, pain management, side effects, the theme of eating and drinking at the end of life, also grief, and a lot of other topics. Yes. I mentioned before the palliative care coordinators. They are responsible for the development as well as the professional and organizational collaboration of the palliative care group. They form the group, they implement team building measures, they set goals and work assignments. They have a look at all the documents that exists in the nursing home. From the assessment is mentioned that we have palliative care in our nursing home to the residents when they move in, for example. Yeah, The palliative care coordinators make hospice culture and palliative care visible to the staff, to the managers, in the marketing, and they try to support managers by regularly integrating hospice and palliative care topics into already established structures. They assist with budget planning for hospice and palliative care, to plan the next steps and participate in different meetings. They make sure that hospice and palliative care becomes visible in the care and support process. As I mentioned before, in supplementing and adapting existing documents. They ensure workshops on trainings in palliative geriatrics. They attend themselves the trainings. They present at the beginning and the end of the trainings so that everyone in the house knows who is the palliative care coordinator in our house. Yes. They also regularly exchange information with the managers on goals, performances, and indicators. And they often clarify expectations, they ensure sustainability, and support the ongoing development of hospice and palliative care.
And Maria, this is such a innocent line here, improvement with stakeholders. I suspect that also involves doctors, right?
Yes.
Which is quite a task, probably.
Palliative care coordinators also do networking with hospital discharge managers, specialist hospice and palliative care units, emergency services, general practitioners, the pharmacies, to improve the collaboration on residents which need palliative care. Yes, I have a look. So the next project is Hospice and Culture and Palliative Care in Home Care Services. As I mentioned before, it's the same structure and content. And there are 95 home care services nationwide which have implemented the project at the end of 2023. And let's start now. And the project started with 5 home care services in Vienna. And the differences are that the setting is different and the trainings only last 24 hours and not 36 hours. And the involvement, sorry, it's always automatically. And the involvement of the family and friends is more important than in the nursing homes. Yes, and the last slide I would share with you is the so-called about the so-called Vorsorgedialog. It's a nationwide instrument for advanced care planning in nursing homes and in home care services for the residents and the patients. And it's a key element of an effective hospice culture. The conversation with the resident or the patient will only be conducted if she or he wishes to do so. The Vorsorgedialog reinforces the residents' or patients' right to self-determination and provides orientation for end-of-life decisions and for emergency and crisis situations. This includes resuscitation procedures or hospital admissions. The Vorsorgedialog corresponds to any other living will as long as the resident or patient was capable of making decisions on his or her own at the time of the conversation. Some residents or patients are not able to decide on their own during the process of the Vorsorgedialog, for example, patients with dementia. In these cases, carers, their relatives, or a person of trust can help to define and record the presumed will. This can support decisions in specific situations as well. So it's a kind of a living will. Yes. Thank you for your attention, and now it's the time for your questions, which I'm hopefully able to answer.
Thank you, Maria. I would just like to add some background that I noted down. Thank you, Maria, for this very concise presentation of a very complex project. More actually. I wanted to add that it started quite a long time ago, coming out of dementia and palliative care. And actually one little seed of it was from Bosch Foundation in Germany, who had developed the storytelling training, and then it was taken over by the hospice care movement in Austria and adapted, and it really grew and grew. And from this training, it developed into an organizational development project, which has a really, I think, very ambitious approach. But of course, as you can imagine, that needs quite some budget. And the very different numbers that you saw in the columns for where it is implemented are due to the fact that in Austria, as in many countries, or at least in Germany, I know that the regions and the provinces have their own budgets and assign budgets to long-term care. So if you have a very high column, for instance, in Vorarlberg, it means that they spend a lot more money for it than other provinces, for instance, Salzburg, which has 0. But we have a bit of a fortunate situation, which came about when assisted suicide was made legal in Austria. It was linked to a new law, which is called Hospice and Palliative Fondsgesetz, and the government assigned quite some money for extending the palliative care in the country. And this is something that we can draw on a little bit, but the primary focus of that funding is the specialized care that Maria mentioned, so that the opposite of the Grundversorgung. And in fact, one of our lobbying topics in Diakonia Österreich is that we need more of that money to go into the Grundversorgung, because as Maria showed, 80 to 90% of the people do not die in specialized hospice care surroundings. And we really need to get the training and the attitude and the culture into the Grundversorgung as well. So I'm very happy that Maria and Hospice Austria support us in that endeavor. We need to expand the specialized care, of course. A lot has been done for children, for instance, in Austria recently, but we really need to look at those groups that are often overlooked. And, with dementia, it's like, what can you do anyway? There's a certain attitude from in the budgeting and then the funding. So what I really also like about this approach is that, for instance, in nursing homes, in long-term care, we get this palliative care approach, this hospice approach, that the relatives are part of the system, that they are really addressees for what we do, and that we can break that often very established top pattern that, is the nursing home and the nursing staff and the people who live there, and that are relatives, and they're kind of complicated or, outsiders. Often, they're even called outsiders. And I think that the palliative care attitude and approach really can help us there, and that is something that we really, really need. Otherwise, we're never going to master the challenges that we have. The budget for the coordinators is quite difficult to get in the provinces. Maria is fighting brave fight there also. So the training and the implementation is one thing, but then we really need, Maria really emphasized the sustainability of this if you train all your staff for 36 hours, I mean, that is a lot of effort, a lot of money and time. And then if you don't have one person who kind of is responsible for that, who gets time assigned, not just a sign at the door or a business card, but really resources to do that, resources to talk to the stakeholders, talk to the doctors who may not have a very good understanding of pain medication, etc. That is really very important. And on pain, I wanted to also add that there was 1 or 2 years ago, there was strong criticism in Austria from the supervising bodies at the national level that there was not enough pain assessment and pain treatment in nursing homes. And of course, I don't know if they looked at those with HPCPH projects, but really that is something that we can address. Knowledge about pain assessment, this knowledge that people with dementia cannot express their pain, but they experience pain, and what we can do against this. So that is a really, really strong benefit that we get also from this project. And another thing, because third country nurses are a big topic everywhere now. And I think it is also really a very big cultural opportunity to acquaint the new nurses from India, from the Philippines, from Vietnam. These are the main countries in Austria at the moment, with how we see long-term care, how we see treatment of patients with dementia, how we deal with dying and death, and give them some orientation and support also really to get into this attitude, into this culture that we want to, in a good quality long-term care, want to implement. So I think that that is also a really important group to address there. And I had one more thing to say, but I forgot it. So yeah, I'm really very glad we have this. I think it's a huge benefit, and it can. Oh yeah, I know what I wanted to say. That's kind of the basic information that the people who are in long-term care in nursing homes in Austria today, they have a very, very high need of care. We have Pflegestufen, so we have 7 steps, and 4 is usually the point where you can even go to a nursing home. So you're usually multimorbid, you have various diseases, you're probably under polymedication already, you're not very mobile usually, and we suspect 70 to 80% you live with dementia, and the time that people live in those institutions is really going down. So sometimes only 3 months. And I usually say, when I want to really get to people thinking, is that I say we're really gerontopsychiatric palliative care units. So we have a lot of topics of gerontopsychiatric patients, but also people who get to us in a state where they really, really are palliative care patients. And we need to address that. And by this project, we can do that. And I think that's why we really need to get it rolled out fast. And what Maria didn't mention was that there's, of course, a huge body of trainers who get the training program and who do this training, who know that, who have the hard facts. Usually there are 2. One of them is a nurse. The other one has different qualification, sometimes doctors even. And they really have good training in this storytelling approach, which is very instrumental in doing 36 hours of training and keep people interested and get the message across. And they also have very good factual knowledge. So yeah, thank you.
Thank you so much, Maria. Thank you so much, Petra. That was really, really informative. Thanks a lot. I will encourage us to ask our questions. Last week, we looked at the spiritual care, and this is really like the nursing home and the care, the palliative care. When you were talking about the stakeholders, I was looking forward maybe to hear like maybe the spiritual part of it. Is that something that comes up in your project, like the spiritual care in palliative care?
Yes, we have we have meetings with, as I mentioned before, with the general practitioners, with the pharmacists, with the emergency services, with the specialized hospice and palliative care organizations, and we sit together and think about how can we improve the care for our palliative patients in the nursing home. And these are 1 to 2 times per year, or it's very different. Some nursing homes have already established meeting structures with these stakeholders, and sometimes it's 3 times a year, sometimes it's 1 time a year. So it's different, but it's also in the project. And
Kim, I'm not sure. Were you asking about spiritual care? I didn't quite understand it.
Like is there a relationship in the case in Austria between the spiritual care and palliative care? If the person's need of care requests the spiritual care of it, is it part of the project?
In the trainings, there is a part, what does spiritual care mean at the end of life for the residents? Yes, it's I guess 1 or 2 hours. It's about spiritual care in the trainings for all the employees, for all the members, staff members.
We have special trainings for spiritual care in Austria, in Vienna at least, longer trainings. And I think what I like also about the project is that spiritual care is no longer than just only a separate discipline, but it is integrated in this understanding of palliative care. Of course, going back to Cecil Saunders, spiritual care is a basic need or a basic element of that. And it really, everybody from the kitchen to the nurses gets this understanding that these are people who have spiritual needs. And, how do I deal with them? Will depend on their backgrounds and their functions. But it really puts this spiritual care need, as say founded by Cicely Saunders, into the center of the culture. But of course, there are also chaplains, from various denominations working there, often voluntary, more rarely now paid ones. Budgets are being cut by the churches as well.
Thank you so much. Does any other person have a question? Or we can just discuss what is happening. There is something, Petra, you mentioned towards the end, and I already heard it in Norway, that because of the push towards more home-based care, people stay at home longer. And at the time they go into the care homes, they're already coming, that before they used to come with their, walk in with their bags themselves. But more and more they're saying that they're coming in with ambulance or something like that. So they're coming in at the point where it's not just the elderly care, but they need palliative care as well. Is that something that you're also seeing in your countries? Because I heard it already that that's the case now in some regions in Norway. People are not just coming in with their bags by themselves well and doing, but they're coming in ambulance, for instance. So we can also just discuss what is happening in other countries. Yeah.
I'm sure it's true for Germany, Hannah, right?
I would give the floor maybe to Anne-Christine. I think she can say more than me on this topic.
Just try to tease somebody out here.
Yeah.
Yes, thank you. I'm Anne-Christine Linde from Germany, from Evangelische Heimstiftung. And first I want to thank you for this interesting presentation. I saw lots of similarities to our organization. We are a big träger of 100 nursing homes, and we have lots of similar strategies. And to address the question, I think it's it's a big problem in Germany too, that the residents of our nursing homes come late and in a high age into our nursing homes. So to make it possible that they can die in our nursing homes is a big goal, maybe a central goal of our palliative care concept, that they, at least in the process of dying, they don't need to go to a hospital anymore. And this needs a lot of competence in the nursing home, and this needs a lot of strategies and also an external cooperation with specialized teams, so we can yeah, sicherstellen.
Ensure.
So we
Ensure.
can ensure this. Yes, thank you. Yeah. And
One
also
problem.
this is also this Vorsorgedialog is also a important part to ensure that people don't need to go to a hospital anymore. And in Germany, this is called gesundheitliche Versorgungsplanung. Yeah.
Of course, one of the obstacles to what Ann-Christine just described is the availability of doctors in the nursing homes. And our ministry is just doing a survey of how good the coverage actually is of doctors. And we at Diakonia, we have one small project now where we can employ a doctor, a general practitioner, for 3 nursing homes. And we hope that this will make it a little bit easier, because these are people who then have complex needs, and it's just a difference if they come by once a week and see 20 patients, or if they're there. And the nurses have more security. The nurses, they have a lot of fears, of course. They are under intense pressure. And when it comes to people in late stages and sending them to the hospital or not, they need reassurance. And having a doctor present, of course, is a big help there. So we'll see what the results are from this small project.
Okay, thank you so much, everyone. Is there another question? If not, then we've gained maybe 16 minutes. It's just 16 minutes, so. And yeah.
I would be interested in your Vorsorgedialog project. We implemented also advanced care planning in our nursing homes, and we often think that we address the people quite late in our nursing homes. So we think it would be better to implement advanced care planning earlier in the life of the people, maybe with our mobile care, ambulante Pflege. And I would be interested about the situation in Austria. Do you have the Vorsorgedialog only in nursing homes, or is it also accessible for people living at home?
It's also accessible for people living at home. We train our home care services to really make the Vorsorgedialog with their patients, but you need a general practitioner to make the Vorsorgedialog, a nurse and a general practitioner, and that's what Petra mentioned. It's very also in the home, or even more difficult in the home care service, to get a general practitioner who comes to the patient's home and has 1 hour to talk all the topics of the Vorsorgedialog with the nurse, and in the best case, a family member through. And another issue is that 70 to 80% of all people who move into a nursing home suffer from dementia. So advanced care planning and dementia is really problem and takes a lot of time to also to when you try to get to talk with the relatives, family members, what the person would like to have when he or she was we call it entscheidungsfähig, also when he could talk about what he wants or not. And this is it takes even more time that does not exist yet. So it's a great, really a great problem. Yes. Yeah.
Thank you so much. Chris, you have a question? Maybe you can unmute yourself, sir.
Yeah, thank you. Really, my name is Ebenezer anyway, but the Chris over there is a borrowed phone, but that's all right. I'm very sorry that I joined very late anyway, from Birmingham in the United Kingdom. I just want to ask, is there any spiritual provision for people in the hospice in your area? And if there is, what kind of are they multi-faith or a specific religious organization only? Because here in I'm a chaplain with one of the NHS trusts, and we operate a multi-faith chaplaincy. So is it the same over there, or there is different? Thank you.
Yeah. I don't. Kevin, can you? I'm not sure I understood everything. Kevin, can you rephrase it or repeat it?
Yeah, I'm asking if there is a spiritual care provision for the patients in the hospice there, and if there is, are they multi-faith? Like we have, I work as a chaplain in one of the trusts here in England, in Birmingham, and it's a multi-faith chaplaincy. Is there anything like that for people over there too, or not?
Mm-hmm.
Maybe it's better, maybe throwing more light to it. Do you mean like with different religious backgrounds? Or
Exactly. Yes, that's what the multi-faith ritual care is about.
Yeah. Multi-faith was the part that I was in the dark. I think that all of the but Maria, correct me there. I think that all of the organizations really are very sensitive to the various spiritual needs. That in the training in hospice and palliative care in general, there is a huge focus on multi-religious needs and practices. And I'm always very surprised, actually, when I used to work in adult education, further education, and when we had lectures on, interreligious needs in hospice and palliative care, those were always the most popular. So there was a huge interest in the hospice and palliative care scene in dealing with people from various backgrounds. In Buddhism is always especially popular, but also a huge interest in how to deal with people from Islamic faith and also agnostics, so people have no faith, of course. And I think there's a huge sensitivity in the field for that. And I think it results in really, especially in the specialized units, people doing a lot to have access to their, spiritual contact persons, if that is a preacher or an imam or a chaplain or a pastor or whatever. So I think that we will have special partners, mostly not on personnel. I don't know about that too much. Usually it's partners, people that come in either as volunteers or as paid chaplains or seelsorger, spiritual care specialists, and but also if there's somebody where there's no contact yet, but they have somebody from a different religion, to really enable that. I know there's a lot of openness to that. Does that answer your question?
Yeah, that's all right. Thank you. Thank you very much.
Claudia, I noticed that you were nodding along. Also, a lot of interest in Switzerland for that.
Yeah. Thank you so much. Okay. Claudia, you have something? Go ahead, please. We can't hear you. Sorry, Claudia, if you can hear us, we can't hear you. Sorry. Could you maybe type?
But I think in general, that is also what I described now is one of the things that hospice and palliative care can really add to long-term care as a special quality. It's the pain thing is the one thing, the openness to really being there for the person, not sending them to hospital is the other, but also this, that the various aspects of hospice care as described by Cecilia Saunders, also the social aspects. I think that this is really a huge asset and a really good add-on to the nursing competency.
Okay, I think while Claudia is typing, just to remind us that we'll have another session next week on Tuesday, and we'll be going to the Netherlands. So we've had Switzerland, we had Austria today, and we'll go to the Netherlands, and then we'll go to Germany. So you can save the date. Next week will be on the 9th of September, 9th of course of September, and we'll also meet at 1 from 1 to 2:30 or 2 o'clock. Let's see how that goes. So we can see the situation in the Netherlands. We can all see the chat. Did you type something, Claudia? Can you see it, Donald? I can't see.
I'm not seeing here. But it's not chat.
Okay.
Chat. Okay. Not to worry. Maybe we can save it for next week, Claudia.
Okay.
Yeah.
All right. Thank you so much, and thanks to you, especially Maria and Petra and everybody for participating. And we look forward to seeing you again next week. And to have a good afternoon, the rest of the afternoon. Yeah. Thank you.
Thank
Bye.
you.
Bye.
Bye.
Thank you. Bye.